Hello, I'm Professor Chris Salisbury from the University of Bristol, and this presentation is aimed at general practices that want to improve the care they provide for patients with multiple long-term conditions. So what's the problem we're trying to solve? 15 to 20% of adults have got multiple long-term conditions, and about 5% or 1 in 20 of the adult population have got at least 3 different major long-term conditions that are included in the Quality and Outcomes framework. And these individuals are often invited to multiple different review appointments at which they see different nurses who just focus on one single condition like asthma or diabetes. And they use different templates for each condition. So there's a lot of duplication of effort with the same questions getting asked over and over again, which is inefficient for practices, but it's also inconvenient for patients. And it treats conditions in isolation. It doesn't consider the cumulative impact on patients of having different conditions, or how treatment of one condition might affect another, and the trade-offs that might need to be made between different priorities. And probably most importantly, it doesn't necessarily focus on the health problems that matter most to the patient, so it's not patient-centered. This is just one quote from one practice nurse. We've always had a massive frustration with how we manage patients with chronic conditions. Most of them have got more than one, and we'd have them come in 1 month for asthma, then in 2 months' time they get called in for COPD. We just felt it was so fragmented, the care that we were delivering, really. So our proposal is that instead of providing lots of individual review consultations, where each condition is reviewed individually, that instead you do one overall review which focuses on the patient and their individual needs. We think that'll be more efficient and streamlined. It doesn't significantly take more time because you're replacing lots of short consultations with 1 or 2 longer ones. And you review the whole patient, including their mental health and their well-being, not just one disease. And as I said, most importantly, it addresses the real problems. It focuses on the patient's needs and priorities and what matters to them. It will help to support self-management by building a sense of shared responsibility for the future. Our approach would improve continuity of care with fewer different people being involved, which is more professionally satisfying for the staff. And also a whole person perspective creates opportunities to access other appropriate resources via social prescribing. Here's another quote. Yes, by doing it this way, with three or more multiple conditions, means the condition is not going to get left out, whereas we were always leaving out conditions before because the diabetic nurse might do a bit of COPD, but wouldn't do the asthma as well, and the asthma nurse wouldn't do hypertension at all, but this means they're all getting done. So what would this new model look like? Patients would get recalled for review once a year, and the annual review includes an initial consultation to collect information and do necessary tests, a structured medication review, and then after they've had their initial consultation, you send the patient their test results and a patient preparation document to encourage them to think about their priorities and questions they want to ask before they come back for an annual review consultation, when they can discuss their test results, they can discuss the information collected at the initial consultation and make a plan for the future. And this is all supported by one computerized template rather than swapping around between multiple templates with different templates for each disease. Another quote from a practice nurse. Yeah, I think it's really good for the patient. They don't have to keep coming for multiple blood tests, multiple trips, unnecessary blood tests as well. And it's all as one, so that's good for the patient. So what does the annual review include? It includes all of the following in one integrated streamlined package. It starts off with a focus on what matters to you. The very first question is, what's most important to you in terms of improving your health at the moment? And patients are given an opportunity to discuss their values, their priorities and goals. The template includes questions about quality of life, pain, well-being. It includes a brief assessment of their mental health as well as their physical health. And it does obviously all the usual things that you would need to do in a disease review to ensure that they're getting optimal medical management for each of their chronic conditions. It encourages a medication review with a focus not only on the individual drugs, but on how we can simplify treatment and how we can improve medication adherence. It encourages a support for self-management and referral for social prescribing where that's appropriate. It includes thinking about who are the carers and do they have needs. And it includes making a plan for the future, which involves discussing with the patient the effectiveness and goals of treatment and sharing decisions with them about what their future management should look like, which might sometimes include stopping some treatments. So it ends up with an individualised care and support plan, which is printed off and shared with the patient. So how would you go about making this change if you're interested? I want to put forward a 9-step plan. First, create a small planning group, which includes the person responsible for running the recall system, an HCA, a nurse, a GP, and a pharmacist. And those people need to work together to implement this in the practice. 2, you need to identify a single computerized template. Now, we were involved in helping to develop the Ardens multimorbidity template for Emis, but there are other alternatives available from other suppliers, and some ICBs have developed their own. But many of the other templates I've seen are basically just a collection of QOF-focused templates which just address clinical needs rather than being aimed at personalised care. Thirdly, identify who are the patients you're going to involve with multiple long-term conditions and potentially complex needs. Who are the people who would most benefit from this kind of whole person review? So in our work, we've chosen people who are on at least 3 different types of long-term conditions from different disease systems. So maybe diabetes plus COPD plus depression. Or you could focus on people with multiple long-term conditions but who've also had more than 12 consultations in the last 12 months. We've created a tool for Emis practices which enables them to identify people who are on 3 different types of long-term conditions, similar to what we used in our research. Or you could use the Ardens recall program if you have Ardens, or your ICB might have their own risk stratification tool. Fourthly, training. And there's different aspects to training. Firstly, clinical training. The clinical staff doing these whole person reviews need to be competent to do at least a basic review of all the common major long-term conditions, particularly chronic cardiovascular disease, diabetes, respiratory disease, depression and anxiety, and dementia. Now, they don't have to be able to do everything that a specialist nurse would do for each of those, but they've got to be able to at least do a basic review and identify who needs more help. And we've developed a curriculum that you can use as a sort of self-assessment and any member of staff can use to see what are the skills they really need to do this kind of general whole person review, which ones have they got already, which do they need to learn, and how can they get those extra skills, with some links to resources for training in those extra skills. And then there's consultation skills. This approach involves shared decision making and creating a personalised care and support plan. And some clinical staff haven't had much training on those kind of issues like shared decision making. And we worked with Year of Care partnerships, and they've got excellent training opportunities, and other opportunities are available from the Personalised Care Institute. And you can get links to all these things on our website. And then operational training. One key aspect is making sure that clinical staff know how to use the template, but the admin staff know how to run the recall system, how to book appropriate appointments, how to send out the patient preparation documents with the test results, and that all needs thinking about. Here's another quote from a practice nurse. I think it's reassuring in that you know you're covering it all, so you're not missing anything. When someone's got like 5 or more conditions, you can quite easily miss one, whereas obviously on your multimorbidity template, they're all lined up. So you literally click from one to the other, so it's there. You're not missing things, and it's easier in that sense, definitely. And here are steps 5 to 9 of the plan. First, process mapping. The planning group needs to work together to map out in detail what happens currently in your recall and review system, and map out what needs to happen instead in the new system. And we provided links to a recent guide to process mapping and an example from one practice. And then 6, make a plan. There are different elements to this. First, the administration. Decide how you're going to book the appointments, how long for, which member of staff is going to do what, how to send the patients their results and the patient preparation document after their initial assessment and before the annual review. And then a maintenance plan how you're going to stop patients being recalled for separate disease-focused reviews as well as this whole person review, and how to ensure your register of patients needing annual reviews kept up to date as new people acquire diagnoses and become eligible. What about continuity and coordination? We think continuity is particularly valuable to this group of patients with multiple conditions. So think how you can encourage continuity of care with the minimum number of different members of staff and the roles and responsibilities of different members of staff. Start small and build up. Don't try to do everybody all at once. Start with a target group, perhaps people who've got diabetes and multiple conditions, and then once you've piloted with that group, then spread it out wider. 8. Monitor the number of patients who've had a review and the proportion who've had different key elements of the review. We've designed an example audit tool for use in Emis, which you can download from the link below. It's designed to be used in conjunction with our search tool and the Ardens multimorbidity template, and it shows whether some key elements of holistic care have been completed within the last 12 months. And you could look at that tool and modify it to suit your own needs. And finally, consider forming or joining a peer-to-peer community of practice. We think this works best if you do it with a group of practices in a network or an ICB where they can do it together, share ideas, solve problems together, offer each other support and suggestions. Now, if you scan the QR code at the bottom of the screen, it'll take you straight to a transcript of this talk, which has got links to all of the different tools that I've mentioned. Another quote from an advanced nurse practitioner. That question, what matters to you, got answers from the patients that meant something to that patient. One particular patient had pretty poorly controlled diabetes and had some really bad depression. They said, I'm really isolated. I'm drinking loads of alcohol because my daughter died. They didn't really care about their diabetes. And being able to home in on that, I was able to then slowly unpick it and feed them back into social prescribers. If we'd just done a diabetic review, we probably wouldn't have got that information. And another quote is done from a patient. She involves you in it. You know, she'll say, have you got any concerns? And she makes it clear that if you want to ask questions about anything, then you're free to do so, you know. You're not held back in any way. You feel that you're being spoken to one-to-one like, and it's second to none, I'll say that. So that's a good example of patient-centered personalised care. Now, I'm not going to suggest that this is all easy. It's quite a big change, and these ideas are all based on research we've been conducting over the last 10 years, and we've learned several things that you need to consider if you want to make this a success. First, don't underestimate the difficulty of designing a template one template that's going to support review of patients with multiple long-term conditions. The first study I did like this, we did our own homemade template. It was a lot of work and very difficult to support and keep up to date. So we've decided it's more sensible to use a commercial product such as the Ardens multimorbidity template, unless you've got your own dedicated team of IT support staff that can keep on top of developing and supporting and revising the template. And there are other commercial templates available. Then how to run your appointment system efficiently, including how you're going to book sequential appointments for the initial consultation, the medication review and the annual review consultation. Think about how you're going to generate and send the patient preparation documents to patients. We used the Year of Care patient preparation documents, which are also included in the Ardens multimorbidity recall system. In our research study, some patients we recommended doing 2 consultations, an initial consultation and an annual review, and that these should be longer than usual consultations. But some practices tried to do everything in one consultation. And that meant that the test results weren't available at the time of the review, and the practices and the patients found it was just too much to cover in one consultation. So they started leaving things out, and the thing that they most left out was making a care and support plan, and that's one of the things that the patients most value. So linked to that is how do you make sure your appointments are long enough? And these do need to be longer than conventional single disease reviews. But remember, they're instead of a series of separate reviews for each disease. Another key issue is that many staff are unclear what's meant by a care and support plan. And there was a lot of confusion with disease-specific plans like asthma action plans. Now, if a patient's got multiple long-term conditions, they can easily end up with a confusing array, a kind of library on their bookshelf of disease-specific plans for asthma, for diabetes, or whatever, and nobody ever looks at them. And we think it's just confusing for patients, and why we think providing one holistic plan, which is focused on the patient's priorities, is important. So, given that many staff are not familiar with making care and support plans, you need to get the training for your staff. And it takes time to train staff. So you might want to start with a small number of staff who can manage a wide range of skills, and then make a plan to upskill other staff over time. We found that some staff are comfortable having skills in a specific disease, perhaps they're the diabetes specialist nurse, but maybe unenthusiastic about reviewing any other conditions as well. And I think we need to make the case that most patients who've got one major disease, such as diabetes, have got other conditions as well. So we do need a more generalist perspective, both for good patient care and to be efficient, unless they're going to see numerous different people, one for each of their diseases, and this will apply to large numbers of patients. Another issue was QOF. We found that some staff, when they're feeling pressurised, and everybody is pressurised in general practice at the moment, they felt that the key priority was to fulfil the QOF requirements, and anything else is a luxury. But QOF is changing, and the key thing is it was never intended to be a comprehensive guide to doing good general practice, and focusing solely on QOF, I would argue, leads to poor care, and it's professionally unsatisfying, as well as not good for patients. So all of these ideas are based on research that we've done, as I say, over the last decade. One big thing was the 3D trial published in The Lancet in 2018, where over 1,500 patients from 33 general practices were randomly allocated either to a personalised whole person review or to usual care. And our 3D approach led to improvements in personalised care, but it didn't improve quality of life. Both patients and staff felt the new way of working was an improvement, and it turned out to be no more expensive than usual care. But many practices struggled to fully implement the approach, and the fact that it was introduced in the context of a randomised trial for a small number of patients in each practice made it even more difficult. So in the later PP4M study, we focused on some of those implementation problems that we experienced in the 3D trial. What are the problems that people have, and how can they be overcome in implementing this kind of thing? So we worked with Ardens to make their existing multimorbidity template more patient-centred. We talked to Year of Care partnerships about the needs for patient preparation and staff training. We supported 16 general practices to introduce the new approach, we call them implementation practices, and we compared them with 16 control practices that had got access to the template but no other support. And what we found is that multimorbidity, these people with at least 3 different conditions, is very common. It's 4% of all adult patients, which rises with age to about over 20% in patients aged over 80. And almost everybody who's got these multiple conditions have got at least one cardiovascular diagnosis. More than half of them had got diabetes, more than half had respiratory disease, and more than half had got a mental health diagnosis. And that's why, if you want to provide coordinated, personalised care for this group of patients, staff have got to be confident to manage people with all of these problems. In the PP4M study, the implementation practices used the multimorbidity template with over 2,300 patients in the first year, which is about half of all the patients with 3 or more conditions. And they were more thorough in assessing a broad range of patient needs, for example, mobility, memory, falls, pain. And although it was a comprehensive review rather than a disease-specific review, the disease-specific reviews improved as well. More people had got reviews of their diabetes, of heart disease, stroke, atrial fibrillation, COPD, and mental health problems. Now, many practices worry this will all lead to more work when they've got too much to do already. But remember, you're replacing lots of separate disease-focused consultations with 1 or 2 longer patient-centred consultations. And these patients do take up a lot of time and consultations, but they do anyway. We found that before implementation of the new approach, this target group with multiple long-term conditions generated a large number of consultations, about 13 consultations per patient per year. But reassuringly, introducing the new way of working didn't generate any additional consultations on average in the implementation practices compared with control practices. And we found, as we'd found in the 3D study, that most practices and patients appreciated the new way of working. Patients particularly appreciated being asked about what matters most to them and have everything dealt with at once. And staff appreciated the efficiency gains and not having to swap between different disease-specific templates, and feeling that they were identifying the important problems that might otherwise have been missed. We found there was a lot of variation between practices in the extent to which they introduced these new patient-centred reviews. And implementation difficulties included difficulties scheduling the initial and annual reviews, a lack of staff engagement with the concept of care planning, and many nursing staff lack the competence or confidence to manage problems outside their own disease-specific expertise. And many practices felt overwhelmed by excessive demands, and what happened then was staff tend to prioritise the disease-specific aspects of the review that they're already familiar with, and the aspects of care incentivised by QOF. And successful implementation will rely on addressing those issues around training and talking about good care and what's the purpose of QOF. But our belief, backed by this evidence, is that it is worth it. This will lead to better, more personalised care, which addresses patients' real needs and without generating any extra work. So thank you for listening. I just want to finish by acknowledging all the many people who've been involved in this work listed here, and the National Institute for Health Research that funded it. And you can find out more by following the link on the screen below.